So the reason that we were interested in doing something on critical thinking is because we really wanted to be sure that the kinds of deficits that were published and unpublished were not so much because clinicians were inherently incompetent. It had far more to do with the fact that clinicians were not trained how to think critically, specifically as it relates to dysphagia management. So that means that helping somebody to work their thinking or wrap their brains around a concept of why the pharynx is doing one thing but the larynx is doing something else is not necessarily inherent. We really believe that it needs to be taught. So in this course we spend some time talking about system 1 thinking, which tends to be automatic, rule of thumb, things that people have told you, versus system 2 thinking, which is where you really need to analyze a situation, really think about the evidence behind it. So those were some of the kinds of things that we really wanted to get across to the attendees.
Yeah, and I'll just sort of roll off what Dr. Humbert said. Teaching dysphagia for 5 years to actually about 15 different classes and online versions and in-class versions in a master's program at the University of South Florida. Historically, the types of dysphagia courses that are taught to the master's level clinicians don't sort of emphasize critical thinking, and it's a little more sort of maybe rote learning of anatomy and physiology, and maybe not even to the extent that it should be taught at. And so we really felt that the graduates that were coming out of the master's speech-language pathology programs from touring around the country and presenting at different research and clinical forums, in addition to our own students and what they were telling us that they needed, that there's a really sort of lack of specialized training on A, how to think critically, but B, the medical setting where we're dealing with these highly complex patients. And when you look at the typical master's speech-language pathology programs, there tends to be an emphasis on more of maybe the pediatric sort of language articulation areas. And while they're very important as well, the medical setting is a lot more complex. There are a lot more serious health issues at stake here where, you know, mismanagement of a patient can unfortunately result in death. Yet we spend maybe 5–10% of the master's program devoted to this. So we really felt that there was a gap there in the education and the type of training, and hopefully we can add to the clinicians and experienced clinicians as well to just reformulate their thinking and apply that to their clinical practice.
The other thing that we try to focus on quite a bit is advocating for your own practice. And sometimes people ask questions like, well, how do I get the radiologist to let me record my fluoros? How do I get my rehab manager to understand that I need some time to look at the video fluoroscopies afterward? And how do I get the administrators of the hospital to realize that we actually need to spend money on something that allows us to see what we're trying to treat and evaluate? And I often say there are a couple of ways that you can go about this, but it's probably not going to be, there's not going to be magic. It's not just going to happen overnight. But the first thing is you really have to build a rapport that you are a clinician who should be respected just like every other profession. I like to say that other departments in a hospital don't have to argue for why surgeons need scalpels. It's just a given. You can't have a surgery department if you don't have an OR, right? Yet speech pathologists, because they're not a department, they're individuals who work in a rehab setting or an ENT or in somebody else's department. They often have to say, hey, don't forget about us. Our patients are important too. And I think what's really critical is you're not advocating for yourself, you're advocating for your patient. An example is if you are doing a fluoro and you're supposed to have maybe 15 minutes in the fluoro suite, and 5 minutes in the radiologist is ready to go and is saying basically we need to wrap this up. It's not my job to tell the patient that you would like to cut it short. It's your job because you are here for a reason as the radiologist to determine how much time we have. So I'm not going to be the person to tell the patient anything. I'm not going to speed up. If the patient's paying for 15 minutes of time in the fluoro suite, then I'd like you to explain, please, to the patient why you're cutting off the fluoro early. And often what happens, it's, well, okay, you have a few more minutes. So if we keep sort of doing, I don't want to say the dirty work, but if we keep sending those messages on behalf of the people who are saying what you're doing is important, but we really can't support it, then we're really never going to move beyond the situation we're in. And the last thing is that if we don't have a united front wherever we are, so if we're in a hospital setting, a skilled nursing setting, and if we all agree that there's a problem, but we can't come together in a civil and professional way to say, this is what we need, this is why we need it, because we're busy sort of doing our own thing, or just dealing with it. Well, I just want to deal with it and somebody else wants to fight, then it's probably really never going to get to the level of advocacy that our patients really need.
So one thing in the course that we also like to focus on is this clinical decision tree template, and really having experienced clinicians think critically about what do we have in our tool belt to do clinical evaluations. What of those measurements are more subjective? What are more objective? And what can we truly say about these measures? We sort of gloss over some of the recent exciting literature that talk about the discriminant ability of different easy-to-use clinical exams that can help guide your thought process. But we really highlight the only way to truly evaluate what would be considered an efficient swallow or a safe swallow would be through direct visualization, either through FEES or in the fluoro suite. We also like to highlight and train the clinicians that, you know, I can't tell you how many times I've worked at several facilities and the physician says, when you come back with the patient, did the patient pass their exam? And this gets back to advocating for our profession and moreover educating the role of the modified barium swallow study. It is not a pass-fail test. And we like to really highlight using your time efficiently and in a productive manner in the fluoro suite. So when did the patient aspirate? Was it before, during, or after the swallow? And more specifically, why did they aspirate? And then sort of like a little detective piecing that together in a physiologic manner to determine, okay, if they did aspirate during the swallow because of incomplete laryngeal vestibule closure, what does the literature say? What does the research say that maybe we could do and try to help include that, to help close off the laryngeal vestibule area and you know, do that more in a physiologically guided manner rather than sort of just going in there, oh, yep, they aspirated, and closing off the exam, which I hear stories from students occur. You know, it really is our role there, though, I feel, to educate, going back to what Dr. Humbert said, educate the physicians and advocate for our role there.
The other thing that's probably pretty different about this workshop is the hands-on component. And so being able to interact with various, well, we could say emerging treatments, but some of these treatments actually have been around for a while, like lingual strengthening, EMST, electrical stimulation, and visual biofeedback. Some of them are newer, some of them have been around for a while, but really being able to ask critical questions about what they actually do. So do they measure what they say they're going to measure? What principles of motor learning and or plasticity, neuroplasticity, can be incorporated into rehabilitation using any of these techniques? That's something that we're really trying to push forward as opposed to recipe following. So I like to say that a clinician should be sort of like someone who can bake brownies versus understands the principles of baking. So I should be able to, if I'm a real baker, walk into anyone's pantry and say, all right, based on these ingredients, you could make scones and you can make muffins, but you can't make bread and you can't make croissants because you're missing X, Y, Z. As opposed to saying, give me the exact recipe for exactly what I need, down to the name brand of flour. That tells you that you need to be told every step of what needs to happen. You need a protocol. So if something different happens with a patient, you can't adjust. It's like, well, the recipe says this, so I guess we just have to stop the therapy session, or I don't know what to do if I can't get this electrode placement for some reason. So what's really important is that the best tool that you have is between your ears. It's not in a recipe book. It's not in a device because it's not in a training program. It's between your ears because no matter what the device is, you should be able to use your critical thinking to use that device to its best ability so that the patient is benefited.
Yeah, and I think that's a nice thing about the course, and hopefully our participants take away. They're walking in with the tools. They already have it there. And we're just helping to guide and train that. And I'm not sure, Ianessa, what you think, but I feel like, when I'm chatting with different clinicians, the blink or their immediate visceral response is, give me the recipe, give me the recipe. And I like your analogy with being able to go into somebody's pantry and depending on sort of what is there, being able to throw together the scones or the bread, although you wouldn't eat the bread, would you? But yeah, I run into that all the time where I feel that the immediate sort of urge of clinicians is kind of give me this recipe with the expiratory muscle strength training, but it's like, hang on a second, let's hold up. What are their impairments, and could that even be beneficial in this case or not?
And that goes back to the system one type thinking, in that education, clinical education, is often somebody telling you, this is what you do, this is the way we work through the situation. It's more of a hierarchical one. Right. Whereas when you've sort of been in other settings, like perhaps maybe a research setting, anyone can ask a critical question, from the brand new doctoral student all the way to the senior principal investigator, and if it's a good question, it carries weight. Whereas I find that in a clinical setting, if a student comes in and asks a really good question that really puts their senior clinician supervisor on the spot and they don't know it, it's like, well, this is just the way we do it. It's not, gosh, that's a great question. Let's put together an in-service or a swallowing ground rounds where we start to look deeply into what we're doing. It's like, let's not question what we're doing in case we find out, oops, maybe we're not exactly sure. Let's just push forward and assume that what we were told is truth.
One thing I'm excited to talk about today as well in a session on trying to apply principles of plasticity, and a lot of things that have been learned from other fields, to be frank. And one of those, well, two of those actually, that I think will be quite important is the concept of salience, which is becoming a really hot topic in the world of neuroplasticity. And with emerging technologies, with sort of these virtual reality type things, as well as the ability to use biofeedback and to make the treatment session salient and important and meaningful to the patient, I think we have a specific advantage here, because food and eating, I mean, that's a primitive, sort of drive, and we can really take advantage of that. Ianessa is doing some really exciting work with biofeedback, where the patient is actually in the fluoroscopy suite, being educated and watching, all the internal workings as they swallow, and it has some amazing footage where a patient, by literally being told, don't let the black stuff go down into that area, which is, the aspirin into the airway, they're able to very quickly in real time learn and adjust. And they probably don't even really at the time realize why, but they're being re-educated. And so we're going to be highlighting different principles of plasticity, such as salience, as well as repetition. And a lot of recent work has highlighted the fact that why sometimes is it that the animal research succeeds and then there's this failure to transfer it to human clinical trials. Some emerging literature has highlighted the fact and really investigated why is it that a lot of animal studies in the basic science world in upper extremity and stroke have successful results, yet when they transfer this or translate this to human clinical trials, there's a failure to really see the same success. And there's a number of reasons why, and it could be motivation of the patients, dropout rates, a range of variables that we can't control. But one thing that has been highlighted is a lack of repetitions. So for instance, in a basic science lab, you can have a rat or a monkey or any type of animal reaching for an hour every single day or 2 hours, doing hundreds or thousands of repetitions. In a human, we have fatigue, spasticity, withdrawals, lack of motivation, these factors. And a recent study that came out of Canada highlighted that really only 10 to 20% of rehabilitation specialists they're spending 10 to 20% of their rehab time actually doing trials, repetitions. And when I have posed this question to speech-language pathologists, if you have a 1-hour session with your patient, how many times are they actually swallowing or doing the repetition? And if most are speaking, candidly, they're like, well, I take Mr. Jones from his bed out to the dining area. That takes about 10 minutes. Then I do some small chit chat. That takes another 5 minutes. And yeah, probably they're only doing trials or repetitions for 20% of that time before I notate, chit chat, and take them back to their room. And so, that's something, one of many different things we'll highlight in the Principles of Plasticity talk of important things to consider.